today. We're going to wait just a few minutes to let a few more folks flow into the webinar, and then we'll go ahead and get started. But thank you again for joining us. All right, thank you so much for joining Centerstone as we recognize National Suicide Prevention Month. We're so excited to be here today for Preventing Youth Suicide, starting a conversation about suicidal thoughts. My name is Robert Lambert, and I'm joined today by three of our mental health experts, Becky Stoll, Dr. Shane Kuhlman, and Dr. Bre Banks. I'll let them introduce themselves here in just a moment, but I want to let everyone know that the National Suicide Prevention Lifeline is available at 800-273-8255 for anyone that feels that they are in crisis or in danger of hurting themselves or others. Again, thank you so much for joining us. If you have questions during today's webinar, you can drop those into the Q&A and we'll do our best to answer those questions at the end of the webinar. And with that, I'm going to turn it over to our speakers to give their introductions. And so Becky, we'll go ahead and start with you.
All right, well, hello world and all of our colleagues out there and hopefully others who are going to take a little time with us this afternoon. I'm Becky Stoll. I'm Centerstone's Vice President for Crisis Services, Suicide Prevention, and Disaster Mental Health, and look forward to spending a few minutes with you all and my esteemed colleagues.
All right, Shane, you can go ahead and introduce yourself now.
Excellent, thank you, Robert. I'm happy to be here today. My name is Dr. Shane Kuhlman. I am the Chief Psychology Officer at Centerstone's Research Institute. It's a pleasure to be collaborating with others here at Centerstone for this webinar. So a little bit about me. I live in Nashville, Tennessee. I've been with Centerstone about a year now. And with Centerstone and others, I collaborate with people in Centerstone and external partners to tailor evidence-based practices that match their clients' needs and increase financial sustainability across our enterprise. So that's just a little snippet about what I do at Centerstone.
Thank you. And last but not least, Dr. Bree Banks.
Well, thank you, Robert. Hey, y'all. My name is Dr. Bre Banks. I am the Director of Clinical Education, also with Shane and Centerstone's Research Institute. And you can probably deduce from the title, I do training and stuff. So a lot of what we do is we work on identifying and building cool, novel, and really effective ways to train providers and how to do the best and how to deliver the best care that they possibly can. Clinically, my specialty is in suicide prevention. And so I've been with Centerstone for about 11 years now, and primarily worked in research or clinical work with a focus on suicide prevention that whole time. And so happy to be here with y'all and to learn alongside you guys from Becky and Shane also.
Excellent. Thank you all so much. So I'm just going to go ahead and get us right into the content. That's what everyone here is for. So this first question is for Shane. Young adults are one of the most at-risk groups for suicide. Can you tell us why this might be and some of the trends that we're seeing lately, particularly as we continue to live through the pandemic?
Thank you, Robert. First, I want to express that young adults, while an at-risk group, are thankfully less likely to die by suicide than any other age group. That said, there is a significant amount of suffering in this age group because they're more likely to think about suicide than any other age group. So depending on the population that we're looking at, depending on the demographics of emerging adults, those between the age of about 15 and 24, they have rates of suicidal thinking anywhere between 10 and 20%. That's a lot, you know, when you think about it. And it's about 1 in 5 young adults and adolescents. So in addition to that, this is the fastest growing age group in terms of suicide rates of the past 5 years, increasing by almost about 20%. So although they're less likely to die by suicide, when a young person does die by suicide, it is just that much more tragic and a lot of years of life lost. So over the pandemic, it's hard to tell exactly what the data will say from the last year, right? Some preliminary data is showing that suicide rates are actually going down amongst white individuals. However, amongst Black and brown populations, the suicide rates are going up, especially amongst young adults. Again, this is preliminary data. The data lags a little bit when we get in terms of suicide rates. But if I could think about some of the risk factors that are being exacerbated by the pandemic that may be contributing to some of these. For example, if someone was struggling with poverty pre-pandemic, they may be more likely to be in jobs that could not transition virtually, such as hospitality. Jobs like that did not transition very well virtually, and a lot of people lost their jobs throughout the pandemic. And especially now, as we're getting to a time when the extra unemployment that people are receiving is starting to diminish in states who, you know, we may see changes in suicidal thinking, suicide rates, but that's yet to be seen. I think in addition to some of those pandemic-related responses, we've also seen non-pandemic-related crises, including the murder of George Floyd, that may have exacerbated some suicidal thinking amongst Black and brown populations. So there's been quite a lot of struggle over the last year and a half for a lot of people. But I will say that we'll have to wait and see a little bit until we get the actual suicide rates data coming out.
Absolutely, I really appreciate that. This next question is for you, Becky. One of the greatest myths that we hear a lot about in terms of suicide is that talking about it will lead someone to do it. Can you talk about why this is a myth and it's actually very much not true?
Yeah, I know it's one that is perpetuated a lot, especially with folks, you know, who don't work in the mental health field, and, you know, sometimes with folks that work in the mental health field. And we know that that's not the case, that, you know, mentioning suicide, inquiring about that with someone doesn't plant a seed that someone then is going to make a suicide attempt or a suicide, die from suicide. We know that. My sense is that myth kind of hangs around and perpetuates. You know, my sense is a lot of times people are very uncomfortable. Sometimes people in the mental health field are uncomfortable bringing this up as a potential thought that people might be having. It's frightening to say, have you ever thought about killing yourself? Now, Bree has probably asked 8 billion people that. Shane has asked 8 billion people that. I, in my career, have asked, you know. But when it's not something that you do frequently, it's scary. It'll make your palms sweat, your heart race, because what if they say yes? And if you don't know what to do for that individual, or you also think what the individual might think, which is that means they're going to end up in an inpatient psychiatric hospital, it is pretty scary. And so I do think there's some reasons that people don't ask, because they do feel like, gosh, this is something, this person's in so much pain, but surely they've never thought this. And I think Bree and Shane and I are here to tell you, if somebody is in so much pain that you even think that might be something they're thinking about, they've probably been thinking about it. And so your asking that really has the, I think, opposite effect of, it's not going to catapult them to think in ways that they have never thought at all. In fact, what it's going to do is show them that you're someone they can communicate and share with. And you're opening up that door. So if you say, hey, seems like you're having a tough time, have you had any thoughts of harming yourself? You're communicating and modeling to them that you're someone that can do that, because they probably, if I had to guess, have noodled around on that a little bit with other people, and they've kind of said things like, I can't take it anymore. I don't know how much longer I can, go on like this. And if I say that to Bree and she goes, how about those Tennessee Titans? Do you see that game on Sunday? Well, she just signaled to me, no, ma'am, I'm not going to be somebody who can talk to you about that. But if I said that to you, Robert, and you engaged me in that conversation, then I go, okay, he's someone that's open to communicating with me about that. And so I think it's really important for people to understand that and to go, we hear you, calm, sweaty, even clinicians, it's a hard thing to do, but it's something that's vital to save lives.
All right, so it sounds like having conversations, even as difficult as they may be, is really important. Shane, can you tell us a little bit about who should be having these conversations?
Absolutely, it's a great question. Gatekeepers are peers, coaches, teachers, family members that could potentially be the gate in between a person who is reaching out and actually getting help. So when we think about who can have these conversations, it can really be anybody that's being reached out to, right? And these people can end up being the gatekeepers. So a lot of my research in my early career has been on help seeking, and in particular, gatekeeper training. So what we see is that young adults are more likely to reach out to peers or family members for help before mental health therapists or even their family doctor. So this being the case, it's important for those who they reach out to know what to look out for and know what to do. Interestingly, there are specific groups of people that young adults may reach out to more. And these individuals that feel like they're reached out to may react in an empathetic manner, but they still may not know exactly what to say or what to do with someone that they perceive to be potentially thinking about suicide.
So what might be some of the suicide warning signs or behaviors that the gatekeepers can be on the lookout for, particularly when interacting with young adults?
Absolutely. So one myth, that I often hear is that people who are going to die by suicide don't talk about it. Interestingly enough, individuals who die by suicide often indicate that they're going to die by suicide to someone before their attempt or death by suicide. So talking about suicide is the number one risk factor, right? People may do this indirectly though. They may say, I just think people would be better off without me, right? That's not saying I want to be dead or I want to kill myself, but it's close, right? It's saying that I'm a burden on others so much that I think that people would be better off if I weren't alive anymore. People can say, yeah, I just want to go to sleep and never wake up. They may indicate indirectly in these ways, and individuals can also indicate directly. I'll also say, if individuals start pulling away, young adults start withdrawing from friends, or just stop hanging out with people that they used to hang out with, not talking as often, not calling when they usually call, and also just feel like they are worthless or hopeless, making expressions such as this, and feel like they're not contributing in any way in their profession and in their life with their family. All of these ways might be ways that may be indicative of a growing suicidal crisis. I would say an acute suicidal crisis looks a little bit differently to when someone is actually making actions. So giving away possessions, physical agitation in someone when they just feel like they have to do something, when you might feel like or hear from somebody like, I just have to do something. I can't stand this anymore. You can, this expression that I'm showing, you may see from someone. And at the same time, if they're also expressing these feelings like they're burdened on others or disconnecting from others, all of these may indicate that acute suicidal crisis is happening.
So next question is for Dr. Bree Banks. If you're a gatekeeper and you've observed one or more of these warning signs that Shane has been speaking of, how can you best approach having a conversation with that person?
That's a fantastic question, Robert. And I think both Becky and Shane have already alluded to this, and it's this, the first step in this really is to be a person to whom others can come, right? And there are different ways to kind of indicate that. And one is just in kind of just your regular interactions. If you are starting to hear from folks that if we know that someone's struggling, if we know that someone recently went through a breakup, we know that someone recently lost a job, life might be just getting more difficult for someone than it has before, or it's like a friend that maybe just struggles perpetually, right? Just having a conversation, even outside of acute or even awareness of a suicide risk, to let them know that when things suck, you can come to me, right? And again, you don't have to be a provider, you don't have to be a clinician. It's just creating a space and being a person who is willing to listen. So that's the first thing, is just creating that. It's almost like a marketing thing, letting folks know that you are a person to whom they can come when things are tough. So that's the first thing. Another is, and Becky was talking about this, is after you've kind of created that environment or kind of laid the land, and are a person to whom someone might share, or you are hearing some of these things in somebody, the first thing again is to listen, right? It is really, really easy for us, both as laymen, laywomen, lay people, and as providers, to want to immediately jump into fix-it mode. You tell me you're suicidal, now is the time, and we're going to call 911, we're going to call the Lifeline, we're going to do this, and this. And sometimes that is required. More often than not, the thing that is most required is giving someone the space to share this part of their story. More often than not, folks, those of us that have been suicidal, in full transparency, I've been one of them before. And I went to providers, or I went to friends, family members, and either dropped hints or said directly, I don't want to do this anymore. I don't want to live this life anymore. And they either said, oh, well, you're not like really suicidal because you're not like attempting today. And it's like, well, I guess not. Thanks for that, man. And then that really shuts down that willingness to talk, or that safety, because this is one of the most vulnerable and painful places that we find ourselves in. So just being there to listen. We don't have to jump into fix-it mode. We don't have to do anything immediately. Just shut up a little and open up a conversation to somebody to share this stuff. The next thing that we know is really, really critical, is knowing kind of how the suicidal mind might work, or the experiences that someone who has been suicidal might have. And again, more often than not, if they're talking to you about it, this isn't their first rodeo. Suicidality doesn't just spring up out of nowhere more often than not. It's a developmental thing that happens and is created over time. And so when we are in that space with somebody, asking someone, tell me your story. How did we get here? What are the things that are happening for you that have led you to this point right now? One of the things whenever I'm teaching clinicians or others, and this is pulled from a particular type of therapy that's been designed specifically for folks that are suicidal, is that everyone does the best they can with what they have. That means, for me, and how I interpret that and use that whenever I'm working with folks who might be at risk for suicide, is to say that life up to now has led them to this point to where dying by suicide is truly the best and only option that they perceive to have. It's truly the thing that they think they need in order to stop the pain that they're in. Sometimes, more often than not, that's not true. There are other options, there are things we can do. So engaging someone and just being able to say, tell me your story. How did we get here? and withholding the judgment. And like, instead of, oh, no, you can't die by suicide. No matter what, you can't die by suicide. I tell my patients, you get to die by suicide if you really, really need to. And I'm asking you to do this work with me for now. Let's try these things. Let's try these things that we think can work to help you to create a life that you really want to live. And if we try that stuff and we find that the pain hasn't gone down, we still aren't able to live this way, we still don't want to live this way, then we can revisit it then. Because creating that space to just let somebody be suicidal, to have those feelings and to have those thoughts in a safe space creates movement. It creates that room for us to be able to actually intervene and prevent and do the next thing.
Thank you for that. So a lot of times when we hear that there are people who are feeling suicidal, but they're afraid to have that conversation because they don't want to be hospitalized against their will. Becky, can you maybe talk to us about how there are so many different options for care depending on the person and what some of those options might look like?
Yeah, this is a message that I really hope that, gets out, and we need to do a better job of this as an industry, is to really talk about the continuum of services that people who are experiencing this can get, just like other, medical conditions that you get. You don't kill a fly with a sledgehammer, and this is the same. You don't automatically need to go involuntarily into a hospital because you're having these thoughts. Depending on where the person is, you can try therapy, like Bree was talking about, where you can, weekly, or if you need to do a couple of times a week, but you can do that because you can safely do that. There's things that can be wrapped around you while you're doing that. You can employ safety plans. You can do means restriction and means reduction counseling with the family, which means I'm going to talk to the family about getting things out of the periphery of the person who's suicidal, whether that's firearms or medication, or they like to drive by this certain bridge. You can wrap some of these things around appropriately at times for people, and they can go to outpatient. And then it's a progression, and only people that need to be in a hospital when it's so severe that you worry about their safety, or they need a medication adjustment that really would require an inpatient stay. So I really hope people can start to think more about this, just like we do in medical care. You might go in and say, this is giving me some trouble, and you get sent to PT or you get sent to a nutritionist. And if it doesn't get better, then you progress down this continuum of service. Sometimes you have to have surgery on that thing that was bugging you went to PT for, but not always. And so I do think people are scared to think, if I say this, they're going to come cart me off. I'm going to be put somewhere against my will. And I do think at times it makes people hold their cards closer to the vest than we wish. And it's upon us as the providers and the professionals to acknowledge this in the beginning when we meet people and create a space that lets them know, hey, we're cool talking about this, and it doesn't automatically mean you're going to go into a hospital. There's whole lots of things we could do, and we would make that decision together, and we can talk about that. So I think it's really important, and I don't know that we've done a good job as an industry of making sure people understand and equate it to a lot of things that are in the medical field, where you just don't automatically do surgery and slap people in hospitals. There's lots of other things that can be done successfully.
Absolutely. I really appreciate that. Thank you. Those are all the formal questions we had for our speakers, but I do want to go ahead and address some of the questions that our participants have entered into the Q&A. So if there are any participants out there that have questions, you're welcome to drop those into the Q&A, but we'll go ahead and get started with these few that we have now. Someone says that they have a family member who's age 25. They threaten suicide frequently, but has never made a serious attempt. they've been going on for years, and they say they can't call 911 every time it happens. They're not sure if this is a cry for help. He's already in therapy, and so they're just looking for ideas for what they should do when this family member has threats.
It's a great question, and I appreciate this person who asked it. It relates similarly to the question below that, actually, that we may address here in a second, in terms of how do we decipher between someone who is thinking about suicide to the extent that they are really preparing for an attempt or to die by suicide, and when is someone thinking about suicide, potentially in distress, but may not, have that extra intent to die by suicide along with it. I think there's a couple of things as a provider. Now, this is through my provider lens, so take that with a grain of salt. But one thing that I think about is that when someone talks about suicide, I typically do a risk assessment with them in terms of asking about, okay, if you're thinking about suicide, have you thought about how you might want to kill yourself? Have you gathered any means to die by suicide? A gun, pills? Is there anything that you've thought about how you might die by suicide? Those things tell me if the intent is there a little bit more. So if they have the means to die by suicide, and they're like, yeah, I plan on doing it tomorrow, actually, or typically the response that I'll get is, yeah, I have some pills that I've considered taking from time to time. I think it's really important in those occasions to make sure that those means are out of their possession, to where they're either locked up at the time of acute suicidal crisis to when an action can take place. I often feel like with family members, they feel completely out of control. Like they don't feel like they have any control over the situation. And that can feel really, really, it can put them in a state of fear for their family member. It can make them feel really, really horrible. So having a plan in that case, making sure that that's up to date. Typically, if someone has a provider and they're thinking about suicide, they should have a safety plan with them. So if they're thinking about suicide, walking through that with them can be really helpful. Making sure that they have one. So if they say that they're suicidal, have you done this? Have you put away these means? Have you, taken the cold shower that has worked for you before when you're thinking about suicide? Any of these things can be really helpful to do. So where there's actions. So I think that doesn't necessarily decipher between what is a threat and what is suicidal, but it gives you an action plan of what to take in the case that the person is suicidal. 911 isn't the best call every time. It may not be helpful for either you or your family member. So I get not wanting to call every single time, but just making sure that you have action steps. Talk to your provider, talk to your family member's provider if they're willing to let you. I think that's a really, really good place, and ask if you can be a part of that safety plan with them. I think those are a couple of things that you may be able to do.
I just want to yell amen, because everything Shane just said, because, my first instinct when I read that first question was, what kind of care are they getting? And is this someone providing care who has all the knowledge and skills they need to have around suicide prevention? Because if my hip's hurting me and you're my family member and I've been going to PT for my hip for 6 months, my hip's still hurting and I'm still complaining about it, and I'm in so much pain, maybe when I go to the doctor, I'm not even listening to what they say. So getting, if you want to be involved in vetting this clinician to make sure they have all of the skills they need around suicide prevention and pulling the family in more, I just think is dead on.
Excellent. So we have another question from a participant. They have a brother with alcoholism and severe mental illness, mania and depression. They say he won't stop drinking. He hasn't been going to therapy or groups. has multiple episodes of suicidal ideation. It has broken down in public recently. Is it normal for this family member to be frustrated and exhausted by their brother's behavior? And is there anything that they can do to help?
Absolutely.
Go ahead, Shane. Go ahead, Shane.
Bree, go ahead. But I just wanted to share, absolutely, that's normal.
Yes. So one of the things that we have a family member with any kind of illness, be it a physical illness, mental illness, something as severe as chronic suicidality and alcoholism and bipolar disorder, one of the things that we often find ourselves in is this paradox of, if I'm going to be a caretaker, care for someone else, I can't also care for myself. It transforms us into this, if I experience these feelings of guilt or even sometimes resentment, if this is a pervasive and kind of ongoing issue, that we are wrong for it, we're bad for it, that we don't love this person as much as we should, and et cetera, which can then put us into a place of not being able to be for them what they need, or to be for ourselves what we need. And so that paradox is a thing that is perpetual, and it's normal in both providers and clinicians and not clinicians. Being a family member and a loved one of someone who struggles in this way has its own really, really unique struggles and challenges. So I just want to validate directly to you, whatever you're experiencing, the thoughts, the feelings, the frustrations are valid, and you are entitled to them. And so Shane and Becky will know that I'll talk about this thing called dialectic, which is part of this other therapy, but we have this dialectic, right? We get to have that the feelings that we have, while at the same time, right, doing what we can to find space in ourselves to do for this person that we love. Because ultimately we do. We love this person. It sounds like you love your brother very much, and you want to be able to be there for them in this way. It just sounds like right now you're in a place of the capacity is just low because it's frustrating. You're tired. You don't know what to do next. So a couple of things that immediately come to mind. There is a community through the American Association of Suicidology, the American Foundation of Suicide Prevention, that does focus specifically on family members and loved ones of folks who struggle with suicide or who have died by suicide. And those communities are rich and compassionate and can really provide knowledge and resource, but also just a place to find peers in that experience, right? And another in this work, how do I put this? You can get help too. And that's, I know, a lot easier said than done, but when we do this work and when we have folks that struggle in this way and we find ourselves feeling powerless or frustrated or whatever it is, that might be a sign to look into, maybe I need to get some additional support for myself, again, in order to create that capacity within yourself to be able to be there for someone else. It's one of the things we really leaned into here at Centerstone over the past year with the Zero Suicide initiative that we have, is this focus on clinician care and caring for ourselves when we do this work, because that is not an infinite well, right? There is a limit to the things that we can do. We want to replenish it, but doing this work is hard, and loving someone with that suffers in this way is also hard. And so creating the space in yourself, either through therapy, through a faith community, through friends, family, through a lived experience community, are some places that you could potentially look into.
Thank you. Another question that was submitted is, as far as terminology goes, are successful attempt and unsuccessful attempt considered clinically appropriate, or is there other verbiage that would be better?
I guess any of us could take that, but there's been a real paradigm shift in the past few years to really get away from successful and unsuccessful and what the connotation of that means around suicide deaths. There's also been a real swing to get away from committed. You'll notice now with, guidelines that went out for media and things like that, it's, we don't talk about people committed cancer or successfully died from cancer. And so there's a real I would say, push in the last couple of years, which I think has taken a good hold, that you talk about people that died of suicide, died from suicide, and then you speak about it in the same way you would deaths from other causes. You're really getting away from the success, unsuccess, and the commit, and really talk about died from or died of.
Excellent. One other question, this comes from another participant. They say, if you encounter a patient who has stressors such as a breakup or other thing that has deepened their depression and grief, they're lonely, more of an introvert, have a hard time making friends, their primary complaint is from loneliness, how can you discuss options to give them, especially when they're already in therapy? Are there groups for adolescents and young adults that we could refer them to?
Absolutely, I could take this. So when I think about individuals that are in this state where they're, suffering from an acute, I would say crisis is probably strong in this case, but acute detachment, it's really important for them to rely on those things that matter the most to them. And truly, if this is someone who has family that they may have went away from because of the relationship, or maybe they went into the relationship hard. I know sometimes when we have significant others that our relationships with others change, like when that relationship changes in a snap, it can feel really odd. It can feel like a loss has taken place even greater than the loss of that relationship. It's kind of loss of your role in many, many different areas of life where others may have had that role in your life before, whether it was someone who made your food with you or a caregiver for you when you're sick or other things like this. It's important for them to look to people that have had these roles in the past, or to others that may be able to take on that role of emotional support, tangible supports for them. So if they have family members that are really big in their life that are really big emotional supports, that's really big. I think I also offer as a provider, one of the key aspects of interpersonal psychotherapy is enabling the person themselves to be their own advocate when they're experiencing a loss. And when someone they know that it is an emotional support, but may not be giving them the emotional support that they need at that time, it's to say, hey, you can be assertive in this and ask for what you need at this time, with those others in their life. So there may be, I guess I say that there may be others in that person's life already, especially for young adults, people they hang out with either peripherally or sports groups or after school clubs, anything like that, that they may have pulled away from. Maybe engaging the people that are already in their life a little bit more and enabling that person to be their own agent, I think is really, really important, especially in those moments where they feel like they've lost some agency and lost a lot in their life.
All right, I believe we have, let's see, one other question. This one's from a participant. They have a 22-year-old son just out of the military, but not out long enough to qualify for VA benefits. He's depressed, has anxiety, and they say he constantly contemplates suicide. He's in the direction of using alcohol and drugs. This is coming from his mom. She doesn't know what to do. Can you all offer her any advice?
I think Becky's probably the best one to tend to this, but again, I'll just say quickly, depending on where you are, there could be like state-based benefits. So for example, in Tennessee, we have TennCare, right? That folks can receive care at a place like Centerstone with the kind of Medicare, Medicaid insurance that's there. So if that is an option for you all, that is certainly there. And there are many organizations like Centerstone that do kind of have that focus on Medicaid and Medicare populations, where if you don't have insurance, it's okay. We will work with you to find you to get you in care as quickly as possible, or to get your loved one in care as quickly as possible. Another thing to think about is the Stephen Cohen military, what is the name of the clinic? We call it the Cohen Clinic here at Centerstone. But it's a clinic system. We have several of them within the Centerstone footprint that specializes exclusively in treatment and psychotherapy for members of the military and veterans and their families. But I'll punt that to Becky so she can speak specifically to what Centerstone
Yeah,
can do.
I hope the person that posed that question will give us their contact information in the Q&A, because we will reach out to you. And I hope you're in a footprint, because there are services that can be offered to your son at no cost to him. And if it's via the Cohen clinics are all over the country, they're for military veterans, regardless of status and all that kind of stuff. So there are services available for him. There are veterans on that staff who can reach out to him and try to get him engaged, because your precious boy is only 22 years old. And we, need to intervene and get whatever issues he's dealing with in front of someone who can provide really good, sound care for him, and figure out, what the next chapter of his life is going to look like. So whoever posted that, please put your contact information, because we more than likely have some solutions for you and your, not only for your son, but for even your family. And it'll get you guys on the road to being able to address that. That one got me fired up because I have a 22-year-old. So I'm like, put your info in there. We're gonna get services to take care of your son.
All right, I think we have time for one more question. So this one's coming from another participant. One is, what does the research show when calling a crisis line? Does it help prevent suicide or reduce the risk? They're interested to know what the overall process is when calling the crisis line and what happens next for that individual.
Great question. I can talk a little bit about the research, Becky, if you want to talk about the next steps for the crisis line piece. So the research surrounding the Lifeline, there's a lot of good research surrounding saying it reduces suicide ideation in that moment for the person, as well as suicide attempts for those people that call the Lifeline. These individuals are trained really well to respond in that situation, really trained well to listen, and really trained well in triaging or connecting individuals to resources. That is what they're really, really good at in that moment, because that's what a lot of people need. They call this Lifeline because they don't know where to seek help, and they also just want someone to listen. Are the two primary reasons why individuals call the Lifeline. And Becky, if you want to talk about the 8 processes involved.
Yeah, crisis call centers are really cool. Back in the day, people had crisis and you would send out mobile crisis teams, and everybody doesn't need a mobile crisis team. And so really viewing crisis call centers as an actual opportunity to intervene. And we see in our own crisis call center really high percentages of calls, probably 50 to 80% some months. We handle those telephonically because the person doesn't need an in-person. So, they're doing risk assessment in the beginning to make sure that, this is not some kind of imminent suicide crises. And if it were, we would address that, whether sometimes in very extreme cases, you have to send life-saving measures, but that's very, very rare. Or we might send a mobile team. But if that's not required, after the risk assessment's done, it's really a lot of what Bree talked about earlier. It's listening, really listening to what the issues are, and then starting to build a deck of problem solving techniques and resources and all the things they may need, and kind of creating a little plan. But then not hanging up the phone and going, well, good luck with that. Have a nice life. But following up. You got to loop the door. You got to loop that door back and make sure that we follow up with them. How did those resources go? Did you get, and we follow up until the person feels like they're ready to disconnect. So it's really, crisis call centers serve not only that initial call function, but also do really good job with doing comprehensive follow-up just to make sure people are getting what they need.
The only thing I would add to that, Becky, if I can, is one of the things that we know is that is really critically important for folks that call crisis call centers and that actually will tell us that they're at risk for suicide, or that they're considering suicide or really wanting to attempt, is to forecast for them what they can expect. So this question is really, really poignant, that not knowing what's going to come next is one of the biggest fears and things that gets in the way of folks actually seeking care for this kind of stuff. Because we don't know what's going to happen. If I tell somebody, are they going to send an ambulance to my house? Are they going to send, am I going to have like the cops show up and take me to the hospital? We don't know what's going to come next. So one of the things that we really prioritize training our clinicians to do is forecasting for, if you call the crisis line, or if you're one of our actual clients or patients, is to tell them, here's what you can expect. I'm going to be entirely transparent with you. We're gonna, everything that we're gonna do, we're gonna plan together. You're not gonna get any surprises. So one of the things we really prioritize and hold as a value here at Centerstone is you're not going to, your autonomy isn't going to be totally stripped from you. This is going to be a collaborative process, and we're going to tell you what you can expect, because that process is really scary, especially when we either have had bad experiences in the past or just have no idea what's going to come next.
Excellent. Well, we really appreciate everyone who tuned in to watch our webinar today. We hope you found it incredibly useful, and that you can take some of this information back into your regular lives. I can point out, if you're looking for more information, tips, resources, we have a lot of information on the Centerstone website at centerstone.org/suicide. There's fact sheets, videos, articles that you may find helpful. And again, just so everyone knows, the National Suicide Prevention Lifeline can be reached at 800-273-8255. And again, I just want to say thank you all so much for joining us today.
Thanks, y'all.
Thanks, everybody.
See ya.